Hey guys, in lieu of the follow-up conference yesterday in M&M, in which we had a few cases of dissections diagnosed with CAT scan, one of which was augmented or helped with the use of ultrasound, I wanted to present a case to you that I actually gave last year at a critical care medicine conference. This was a case of a 72-year-old female who presented acutely to the ER with confusion. She almost passed out, and she was noting some belly pain as well. Those are her vitals. She was hypotensive, tachycardic. Sats were okay. She's a bit tachypnic. So, in the critical care room, this was down in Boston, but in the ED critical care room, we initially put the ultrasound probe on her heart to see what type of function she had. She was hypotensive. We had to decide whether to give fluids or not. So this does help in that acute phase to give you an idea or to guide you to where to go next. And this is what her heart looked like. So this is a long axis view. As you see here, here's your left atrium, left ventricle, right ventricle. This is your outflow tract here. This is a beautiful view because you can see the descending aorta, which helps differentiate between effusions that are in the pleural space, which tend to be behind this descending aorta, or in the pericardial space, which tend to float up above this descending aorta. So if you look at this ultrasound a little bit more closely, there seems to be an abnormality in this ascending aorta. I'm not sure if you caught that initially. It's something as if you do more and more of these things that are aberrant or not normal will jump out at you. And I don't know if you see that, but there's something flapping in this ascending aorta. So immediately we said, I wonder if that's a flap. I wonder if she has a dissection. So again, here's the normal. So a nice, not tachycardic heart with a aortic valve, mitral valve, crisp borders, good EF. This patient also has a good EF, but as you can see here, here's your intimal flap. So it's indeed a flap. Some things that are done to look at the ascending aorta is just measurements. So a measurement greater than 4 at the base of the ascending aorta, this one's 4.5 centimeters, is considered abnormal and dilated. It doesn't necessarily mean they're having a dissection, as people will have dilated ascending aortas without this, but it does help give you kind of an idea or move you along that path. How good is TTE for dissection? A study was done in the American Heart Journal in 2012 looking at this. They had 270 consecutive patients. TTE, or transthoracic echo, was the initial test. It's 25% prevalence of disease. And these are type A dissections, so ascending dissections. That's a pretty high prevalence, and it was confirmed surgically. They determined a sensitivity of 87%, 91% specific. Only 244 of these patients had optimal acoustic windows. The operators were very facile with ultrasound. These are all always considerations to make in these ultrasound studies where they're often done by very experienced sonographers. But they did find a rate of 97% sensitive and 100% specific. So how big is this thing? So, she was confused. She also had belly pain. And you're seeing a flap. The other thing to notice in that last echo was that she did not have a large pericardial effusion, which would make you even more worried, especially with her hypotension. So this is what we mentioned yesterday during conference. Andy actually astutely brought it up, was the use of the suprasternal notch. And we got this view at the bedside last year. It's not too difficult to do. And we can show you in some of our sessions how to do this. You just use a cardiac probe and you put it where you think you would, right on top of the sternal notch, and you kind of aim it downward. As you see here, this is her arch here, and this is the flap. So again, normal is here on the left. This is a suprasternal view. And here's our patient with her ascending aorta with this flap in the breeze here. And this is a little picture of how you're going to do this at the bedside. So what about her belly pain? This is her abdominal aorta. Right off the bat, you should see an abnormality. So pulsatile vessel. This is her SMA coming off here, and this is the flap in the aorta. So this dissection is extending all the way down into her abdomen. Again, normal SMA coming off here on the left, aorta, abnormal here, flap right in the middle of the aorta. What about her confusion? She was confused. Her husband said she wasn't talking right, was mumbling, slurring speech. So we put the probe on her neck, and she ended up having a carotid dissection as well. So this dissection was extensive, going all the way up from the belly into the heart, out of the heart, and up into the carotid vessels. Very neat case. So quickly, which of the following is not a direct or indirect sign of a type A dissection? So again, not a direct or indirect sign. So intimal flap or an intramural hematoma, that's a direct sign. Ascending aortic dilation, we mentioned this. So greater than 4 centimeters, it's an indirect sign. Aortic valve insufficiency, is that an indirect or direct? Probably indirect sign. LVH, not so sure. And tamponade, again, an indirect sign. So LVH is your one answer there. And then lastly, can TTE replace a TEE? I think we know the answer to this is no. That study shows that there are studies being done looking at it. Again, if you see it, it should heighten your suspicion. So just keep in mind doing these tests on patients that you have a suspicion for dissection. And if you see it, great. Let it lead your next test of choice and let it lead some of your consultations and clinical bedside management. Hope this helps. Let me know if you have any questions.